Thank you so much. Thanks for sticking around for the last talk, and you'll be able to enjoy the weekend. Looks like we're gonna have good weather out there. So this is a topic. There's many advances in transplant, but this is one that is starting to come up related to donor organ preservation, increasing quantity of donor organs. And I think it's important for in a perfusion conference for you all to know about this. Is essentially it's using perfusion techniques on the donor in the donor hospital, and this is taking off throughout the country. Also internationally, it was done initially in the Netherlands and Belgium and stuff before it was even done here. So it's an important topic. My disclosures are shown here. Shouldn't really affect too much that I'm discussing today. And a lot of the stuff that's being done with donors is off label. So by definition, that's the case. So why are we interested in technologies or techniques to improve donor quality? Well, and it's because there's 15 to 30% of patients still dying on the wait list, waiting for a life-saving organ. So it's important that we continue to look at ways to increase the number of available donor organs for transplant, and then to make sure that these donor organs have the excellent quality. We know that in lung transplant, the patients come with all sorts of illnesses, some extremely sick, some unable to even get out of bed to go to the restroom or to do any activities of normal living. Some on ECMO devices already flown in from different places around the country. This one gentleman up there in the middle was flown from Hawaii on cannulated, fully cannulated on ECMO in a coma. And very similar story for her. And she had a transplant before that gentleman, had COVID and couldn't, and that was before we were doing transplants for COVID. So clearly, lung transplant can let people live a very healthy life, a normal life afterwards. So it's critically important. But there are challenges to the donor organ and to the field. So one of them, we spoke about donor availability, but let's say once the donor is available, there's primary graft dysfunction, and there's chronic graft dysfunction, so early and late. Both of them can affect the donor organ. The early one is more of a reperfusion syndrome, like a heart attack type syndrome that occurs when the organ is first implanted into the recipient. And then the latter one is more of a 5 to 10 year phenomenon that happens. And we think there's some link between early events that the donor sees and late events afterwards as well. So 50% of patients develop chronic lung allograft dysfunction out by 5 to 10 years after transplants. It's a huge number. And 30% of patients develop primary graft dysfunction within the first 72 hours. So even though it's a great opportunity, it's a great resource, but it's also a dangerous process, and we have to continue to look at it. And going back to the quantity of donor organs, 20% of all donor offers are utilized for transplant. Then 80% of donors are not utilized. And of course, what are the reasons they're not utilized? Because of fear of having primary graft dysfunction or fear of having chronic lung allograft dysfunction. And so that's why we tend to limit it to 20% of this pool. But just imagine if we could access many more organs in a safe way, you would have a huge number of patients being able to live a healthy life afterwards, and be listed for transplant and benefit from transplant. So donation after cardiac death is probably familiar to mostly everybody in this room, but it is one of two modes of donating an organ in the US, and abroad, anywhere. So there's basically one of two ways that someone dies. One is the brain death definition of it. So they had a devastating stroke, intracerebral hemorrhage, some major intracranial pathology. So they are categorized as being brain dead. And there's many tests that go in to verify that. And then they have to consent for donation, and you have to get the family consent. Yeah, even though it's good on our driver's license, it may say that you're a donor, but there's still other multiple steps that go into a standard brain dead donation. Luckily, there's also another option for donation because obviously not everybody dies. In fact, the minority of the people, or maybe 50% of patients that are presented to organ procurement organizations die from brain death. A lot of other ones have a trauma, have a critical illness, have some other pathology, recent heart attack, massive heart attack with no real endpoint, and after numerous interventions and discussions, they head towards withdrawal of life support. And so, and we see that, you know, as well, obviously, in a large quaternary hospital like ours. So in that case, you can still donate your organs, but it's a different way. Since they're not brain dead, the team doesn't have the luxury of examining the organs in their physiologic state. So the heart's not beating, the lungs aren't breathing, the liver is not getting perfused, like a brain dead donor would be. So in a brain dead donor, they make the incision, they evaluate the organs, and the patient's declared dead because they're brain dead, but you can see all the organs in their physiologic state. In a DCD, the support has to be withdrawn, the breathing tube is removed, and the patient has to completely die. So has to die. Usually the window is about 1 hour to 2 hours. It is a witness death, so everyone is there in the room, and you know, as opposed to there's another entity called uncontrolled DCD where the patient is brought in from the field, so they were dead and then brought into the hospital. That's another topic. It's actually a very interesting and evolving platform, as you could imagine as well. But here we're talking about a controlled DCD process. Everyone is in the room. They withdrew support, and they watch the clock, and they wait an hour, hour and a half, 2 hours. You're watching the blood pressure start to drift down. You're watching the saturations drift down. Not always, like 30-40% of the time, they do not expire. And if they don't expire, breathing tube goes back in, they go back to the intensive care unit, and you can't touch them. The only way that you can proceed legally and harvest an organ through a DCD process is if the patient actually expires, and then there's a 5-minute no touch period, where you can't even touch the patient, and then you make the incision. So you can imagine we all, like, you know, we save people from cardiac arrest and things like that after surgery. And that's kind of scary to think that you're going to use an organ after it was depleted of all oxygen and blood flow and the patient was dead, and then 5 minutes on top of that with warm ischemia. So it hasn't taken off as a preferred method for donating organs. On the other hand, it is a huge pool of donors that are presented to organ procurement organizations. So about it's 60-40. 60% of all offers are brain dead, 40% are DCD. So I think it's important that we learn how to use DCD organs a lot more because clearly it's an important niche. 5% only of all lung transplants utilize DCDs. So 95% of all lung transplants in the US and internationally are using brain dead donors. And why is that? Well, number one, there's not a great way to assess the organ. Number two, there's some resources involved. I'm going to travel to Seattle for a DCD, and the donor may not even expire. So that's a challenge. So, you know, we have to take all of that into consideration. And what's the quality of the organ, and what's the longevity of the organ? All of these things factor in. People get a little bit gun shy to utilize DCD organs, despite the fact that over 2,000 DCD donors are available each year, but still less than 5% of them result in transplant for lungs. So there was a DCD registry that was kept up by the International Society of Heart and Lung Transplant, and it actually concluded in 2019, but it looked at 5-year outcomes of patients that were transplanted with a lung from a DCD donor. They noticed the trends, that yes, there was an increase, but kind of a plateau in the use of DCD lungs of 5% compared to 95% of donors using DBD. Interestingly, the outcomes, the 5-year outcomes were actually pretty good in this series. So 5-year outcomes were similar, identical in DCD compared to DBD. And this really kind of inspired the community to say, okay, we need to be utilizing more DCDs. The caveat to that was that these were very selected DCDs. These were centers who had a lot of experience already using DCDs. They knew how to select them. They knew how to evaluate them. But the majority of the way that the donors were retrieved is what we would call standard methods, which is just removing the lungs, putting them in an ice cooler, transporting them, and implanting them. So nothing, no assessment or anything in between. So we discussed this a little bit, reasons for hesitation in using DCDs, lack of consistency in the donor management and evaluation. The way that one center does it in the middle of Lubbock compared to another center in the middle of El Paso may be totally different in the way that the hospital allows a DCD to proceed. Some may allow heparin, some may not. Some may allow only 1 hour standoff, some may only allow 30 minutes. So everybody has their own rules because there's a lack of consistency around this. There's resource limitations. If a substantial portion are not expiring, that's something that we have to think about. There's the ischemic insults from lack of blood flow. And there are inconsistencies in the literature. Even though I showed you that large DCD registry, some small center registries have found more graft dysfunction in those organs early on. So where does TA-NRP fit in? So this is thoracoabdominal normothermic regional perfusion. Basically, it's a fancy word for cardiopulmonary bypass. So we've had some lectures already today on cardiopulmonary bypass. And what this is essentially placing the donor after that 5-minute period of time when there's a standoff, and then they open the chest, is basically cannulating the patient and placing them on cardiopulmonary bypass. Why? As a means to evaluate the organs, to reanimate the organs, get the heart beating again, just like we would in a resuscitation after cardiac arrest, getting the lungs inflated, evaluating the liver, evaluating the kidney. So it's reanimating the donor. Of note, the cerebral blood vessels are clamped when this happens so that there's allegedly no blood flow to the brain. And I would say that's been shown in many experimental models and as well as even in human studies that when you clamp off the cerebral blood flow, that's pretty consistent lack of blood flow to the brain. So what we're going to touch on here is, number one, is this necessary for lungs? Number two, does it improve lung transplant outcomes? Number three, does it place the lungs at risk? And then number four, are there ethical concerns? So these are the pumps that tend to be used. They don't bring in a large cardiopulmonary bypass unit like the way that we're used to, but they have all the same elements of it. So volume reservoir, pump sucker, usually another LV vent, monitors, pump, oxygenator, filters, very, very similar to what we would normally be utilizing. This is a standard cardiopulmonary bypass type setup. Everyone here knows you have a aortic cannula, you have a venous cannula to drain, and then you also have vents and suction catheters. So the TA-NRP packets that people take out to donor hospitals is about kind of half of this. It's just a compact version of this, but it's still a lot of the elements of this. Sorry. So we went through this. There's the pre-withdrawal phase where the team huddles. There's the withdrawal phase. There's an agonal phase where they've withdrawn support and you're watching the monitor and the patient's starting to desat. I can tell you that can last as long as like an hour sometimes, and they still don't expire. You see the saturation is 20% sometimes. You see a lot of hypoxia, a patient barely breathing, but they still have a good blood pressure. And sometimes they don't even expire. So it's the agonal phase can be substantially long, and I think it can have implications on the organ as well. Then there's the standoff time. Then there's the chest entry. And then there's the cannulation, the venting, the drainage, and then then you start to reanimate the organs. After about an hour and a half of being on pump and evaluating the organs, then you remove the organs just like you would. You'd stop the NRP and you remove them just like you would for a standard brain dead donation. So why would this potentially be either a good or a bad thing in lung transplant? Well, for one thing, it kind of caught our attention that one of the biggest risk factors for primary graft dysfunction in one of the largest lung transplant outcomes group registries that was performed in the US, and this came out in 2014, one of the biggest risk factors was the use of cardiopulmonary bypass. And I used to do all my lung transplants and cardiopulmonary bypass. Many people did. And once we realized this, there was still a series of additional studies that had to come out before people tended to change and start doing lung transplants. Over the past 5 years, they're being done usually with ECMO, which is a closed circuit, as you know, no volume reservoir, no air-blood interface. And there's been a move away from using any cardiopulmonary bypass for the lung. The reason that we speculate that the bypass machine may potentially contribute to issues to the lung are ones that everyone here is familiar with. So extracorporeal circulatory support in general causes activation of different innate inflammatory mechanisms and immune mediators that lead to upregulation of cytokines and pro-inflammatory states and coagulation deficits. These are the same things that are also involved in primary graft dysfunction. So there's the same mechanisms. So a lot of people speculate that if you use the pump, that you trigger these pathways and then you reperfuse the organ, and it's kind of a double whammy. So now you have the organ gets a really inflamed state. We looked at it in our center. We had a very large registry that was started out of St. Luke's, and it captured data from 14 transplant centers around the world. And we noticed that even after controlling for covariates, this pattern held true. Not using any support, we had a 12% incidence of graft dysfunction. Using VA ECMO, the VA ECMO patients were a lot sicker though, but using VA ECMO, we had about a 30% incidence of graft dysfunction. And then using bypass, we had a 42.68%. So bypass, exposing the lung to bypass, we had the greatest incidence of graft dysfunction. So there are other mechanisms that we are a little bit worried about with NRP when it comes to the lung. So one is increased aortic afterload. So the heart's not beating yet. They're reanimating the donor. They have a lot of blood flow going into the aorta, and you can get some congestion from the pulmonary veins. Unless you're venting the pulmonary veins, you know that you can get a lot of passive congestion, which we see in DCD donors in general, but especially when you reanimate them with cardiopulmonary bypass. So increased aortic afterload, increased bronchial blood flow, and lack of cardiac contractility during the initiation phase, transient left atrial hypertension, and that can lead to pulmonary edema that can kind of worsen or exacerbate graft dysfunction down the road. Also, if you stay on TANRP for a long period of time, you can get volume shifts that can affect the organ. So these are potential mechanisms that can lead to pulmonary edema that may be of concern. So this was worrisome. We do a lot of DCDs. We did a lot of DCDs before NRP became popular, and we even found that this was going to be a little bit of a challenge because people were already afraid to use DCDs to begin with, but now using this might actually make it worse. But there's more to the story. So in our experience, we went out on 2 runs. There are maybe about 20 cases in the US being done on this for lungs, many more cases for other organs. That's why it's so important for us to look at it. So we went on 2 runs. There was about a month in between each one, and they were dry runs. The donors expired, but there was a lot of edema, and the transplants weren't attempted. We went on 2 that we got the organ, we transplanted them, we had pretty poor outcomes. So we had severe primary graft dysfunction, we had to retransplant one. So we had some reservations. So we'll go through this. So this is the second run that we went out on with our team. We brought devices, gear, personnel, everybody was out on the scene. The patient expired, they reanimated the heart, and we were sitting there and we had all of this edema coming out of the bronchus and in the airway in the donor. And this is before we even had procured it. And we waited an hour after good contraction, and still it was pretty edematous, and the lung was very heavy, and ultimately we decided not to utilize it. This is after an hour on NRP with the heart beating, fully decompressed, and you still see a lot of this kind of frothy edema inside of the airways. And then you see the amount of blood that was actually coming out also that was collected in the canister. So that was one we hadn't used. Then we went out on one, and what's happening now is you go out to a DCD, they don't even tell you if there's NRP. So you show up with your team, you fly out, and then you find out that there's NRP. So that's what happened in this case. We're over there as a 60-year-old donor, less than 20-pack-year history. It was a pretty standard situation, cardiac arrest. They decided to withdraw care, had good blood gases. We went ahead and did the DCD process. They did the NRP process. It lasted about an hour and 41 minutes. The organ looked a little heavy, but not bad. It looked decent enough for transplant. We brought it over to us in a system called LungGuard, which cools it homogeneously 4 degrees all the way around. This is what the lung looked like, a little bit of swelling, but not too bad. When it got to our center, we thought it was acceptable. There was a little bleb, which we sometimes see, so we stapled that part off. But otherwise, the majority of the lung actually looked like it was quite functional and acceptable for transplant. So we implanted this, was the first single right lung transplant, 74-year-old gentleman who was in pretty decent shape. The total ischemic time was 400 minutes. That's from clamp to clamp on in the donor to clamp off in the recipient. It was a pretty standard operation, no issues. But the patient had a very prolonged length of stay. The lung just did not kick off enough horsepower for him to ever completely come off of the ventilator. We had to do a tracheostomy. We had to try to nurse him back. But you can see the right lung actually clearing up. It actually looked okay. This is the transplanted lung. But his left lung was also so bad to begin with, and we just didn't have enough horsepower from this NRP right single lung. So we ended up doing basically another transplant for him. We transplanted his left lung before he left the hospital. And once that was done, he improved substantially and left the hospital. He's actually clinically doing very well. The second time we went out was a similar situation. Our team was out there to do a DCD. And they didn't tell us that this was NRP. In fact, we even asked. I think things changed at the last minute. The liver team really wanted NRP. So when we got there, there was a lot of discussion about it. And we were like, oh, we didn't know this was going to be NRP. We wouldn't have gone, blah, blah, blah. And then they were like, yeah, but there's nothing we can do now. So we're like, okay, well, we're going to have to learn how to do this and make it work because it's just becoming too common. So this was a 26-year-old male, good blood gases, excellent looking x-ray. It was a pretty standard DCD, lasted only 25 minutes and he expired. We did thoracoabdominal NRP. We cannulated the aorta, the right atrium, and the pulmonary artery, and the left atrium because it was a heart donor, but they cannulated the left atrial appendage to try to decompress it. We had flow intervals about 3 to 5.5. We procured the organ. You can see the organ already has a little bit kind of edema to it. It looks a little bit swollen. But we thought, again, like there's these reports, people are using them. It seems like it's acceptable. So it's probably reasonable. What we have is a device that lets us evaluate the organ outside of the body. It's called the organ care system. So we went ahead and put them on that device as a second check. And so we flew from wherever this hospital was in Arkansas down over to our center with the lungs inflated and being assessed on a device. And on that device, it met all criteria. It seemed like it was okay for transplant, good blood gases, but it was still a little bit heavy, and you can see a little bit of froth. We went ahead and proceeded. It was a 54-year-old gentleman, had COVID-related fibrosis, end-stage lung disease. We did a bilateral lung transplant. We started off pump, but once we reperfused the first lung, we had like a lot of primary graft dysfunction. We had a lot of edema coming out of the ET tube, and we had to convert to ECMO. We completed the operation on ECMO. He got actually pretty sick from this. He got a very SIRS type state, multiple transfusions, red blood cells, FFP. left the operating room on VV ECMO, which is not uncommon to rest the lung, but in this case, it wasn't really anticipated. So was about 7 days of ECMO support, ICU length of stay 21 days. You can see his lungs here, though, is interesting. Remember that these got screened in with this second check device, the organ care system device. So we had a feeling that even though we had graft dysfunction, they were probably going to turn around because they were meeting all criteria. And sure enough, by day 3, they look completely normal. And to be honest, he actually did remarkably well after he recovered from this early 72-hour period of graft dysfunction. So it's conceivable. This is, we've always thought this, of course, that the perfusion devices help us screen in or screen out organs that are not good for transplant. So it may be a useful middle ground when we're unsure about the DCD organ or about the NRP. So there's some, despite these early challenges, there have been reports of acceptable outcomes of TANRP in the lung transplant field, but it's pretty limited national cohort. I just want to review this with you. This is the latest, so beyond this, you probably don't need to read about it anymore until they come up with the next series. But this was one that was published by the Hopkins group. It reviewed the UNOS data, which is our standard transplant registry. There were 17 cases registered as using TANRP. Compared to the direct recovery DCDs, the NRP cases actually had a lower likelihood of being on the vent for a long period of time. But we don't know how they got to these 17 cases. You have no idea. We don't know how many were screened out. We don't know how many were attempted. All you see is the select group of 17. But still, that's a pretty decent outcome. Other outcomes in terms of survival and graft dysfunction that's captured in this particular registry, which is not very granular, were similar. So that was good. That was encouraging. That means that these 17 transplants, which were done up until 2022, did reasonable with TANRP. That probably included, by the way, that last case that I showed you, because we of course submit our cases to the UNOS registry as well. So we just don't know those 17 what happens in a granular fashion, but they survive. So that's good. This is another analysis that was done out of the NYU Langone group. So they've published a lot on using NRP for for DCD heart recoveries. So they naturally had to become good at recovering the lungs in those same situations. In this one, there were 44 possible lungs. Interestingly, 30 were discarded. We never know what the reason was for the discard, other than a blanket statement that they just weren't suitable. There was no suitable match. 2 were used for research. 12 were actually used. Those 12 were probably included in the last series that I showed you. But 3 of them, they could see the outcomes. They were pretty good survival, 100% survival at 1 year, and no statistically significant difference to their brain dead donors or to their DCD donors. So that was encouraging again. The Colorado group is starting to become a fan of NRP. They published a good series on 8 lung transplants. Again, we don't know the denominator, but they did 8 using TANRP. Their donor ages were pretty conservative, I think. 16-year-olds to 39-year-olds is a very ideal age for a donor. I mean, not an ideal age, of course, to pass away, but from a donor quality standpoint, that's a very conservative range. They had no postoperative ECMO use. There were no lung-related deaths, but they did have 1 patient with a lot of pulmonary edema. They had 1 die of other complications related to pancreatitis. They say all patients were extubated within 24 hours with a pretty limited ICU length of stay. So this was encouraging. This is what a lot of people talk about when you think about TANRP. They'll talk about this particular paper right now. So they did mention some tips for success, and I know the author and the surgeon, and I think this is consistent with what we've seen. So keeping the lungs dry, if you're going to go out on an NRP case, just making sure the lungs are very, very dry before you even get there. When you do open the chest, early venous cannulation and decongest the heart as much as possible, empty the heart out as much as possible before initiating the TANRP. early pulmonary artery venting, and then early reintubation and ventilation gradually throughout the TA-NRP process and limiting the duration of TA-NRP. These are the elements that they believe were helpful to the success in utilizing those. Leuven then, who was also using NRP before, this is in Belgium, published an N of 2 case study, and their first patient had severe PGD. The other one died of fungemia. So it's not excellent results across the board. There was another study very recently published by Matt Hartwig out of Duke, again, looking at the UNOS registry, 22 patients NRP compared to 40 non-NRP. They found pretty comparable outcomes. Again, I would argue they were probably utilizing that same kind of batch of patients, the same 17. The blood gases were a little bit lower in the NRP group than in the non-NRP group, but other than that, the other outcomes were pretty similar. And then lastly, this series from the Mayo Clinic, again, looking at 16 NRP cases, same time period. So I think a lot of these are looking at the same patients, but they were, again, good 1-year survival compared to the non-NRP cases. So why do we need to continue to even attempt and evaluate TA-NRP? Well, it may be important for liver and for cardiac recovery for DCD organs. In fact, it may be like indispensable for them. And I'll show you why. So while there are options, there are other options. There's machine perfusion. We have small portable machine perfusion devices for all organs. We also have static machine perfusion devices for all isolated organs. But DCD TA-NRP has shown improvements in bile duct complications after liver transplant, and in reducing primary graft dysfunction for heart transplants. So you can't do a DCD heart transplant without some form of reanimation of the heart, because you just will never know how that heart's going to do. So you need either machine perfusion or you need this NRP system. There's a lot of thought that NRP is more cost effective. I mean, I think that's interesting, and I want to hear discussion from the group, but I can't imagine that it's that cheap to bring a full cardiopulmonary bypass unit and perfusionists, and it is human labor and time, but there is this thought that it's less expensive, but I don't know. Most studies for liver and heart NRP are mostly observational. There's never been a prospective randomized controlled trial with this, so that's another thing to bear in mind. But here's one example. This is an observational study for liver. So they looked at cases that were entered into a national registry, pretty decent, but level 3 evidence at best. It's not prospective, not randomized, but still they noticed, and this is what is cited right now as the reason for needing to use NRP, is that the biliary stricture rates that they normally see for DCDs is like unacceptably high. But when they reanimated the donor and in the donor hospital with cardiopulmonary bypass and had blood flow going into the liver right away through the hepatic artery and what have you, that in those cases, the biliary complication rates were substantially lower. And there are other studies that have shown us similar findings. However, this is a randomized study. This is a prospective randomized control study. It was industry sponsored, but this was the Organ Care System Liver Protect randomized control clinical trial with 151 patients, about 150 patients per group. So it's a large randomized control study showing a definite improvement in bile duct complications as well using a machine perfusion system. As this did not include NRP, of course. And also less graft dysfunction as well. So I think there are options to NRP. In heart transplant, this was published 8 donors out of the NYU Langone series. Only one of them had primary graft dysfunction using NRP. And all of them were alive as of the time of that publication, so that was encouraging. The Vanderbilt group uses NRP for almost like all other DCD heart transplants. So there's at least 1 or 2 groups that have published some very decent results with DCD hearts using NRP. But again, there's this competing group this is a randomized controlled trial, 90 patients in each arm after number of exclusions, that compared DCD using machine perfusion device, so beating heart, heart in the box, compared to brain death, which is like a standard donation. And they saw, if anything, better outcomes in the DCDs perfused in machine perfusion. So this is a strong feather in the cap of machine perfusion, and it's probably arguably more rigorous data compared to observational data that we've seen for NRP. Now, in the lung is no different. So the lungs, we also have options other than NRP. We have certainly NRP, but we have portable organ care system perfusion for evaluation of the donor. We can go straight to LungGuard if we don't even think we need to evaluate the donor. If it looks standard, we have standard ICE, or we have a static EVLP platforms. We have a lot of different things we can use aside from NRP, or we could use NRP and then go to all of these. This is a study that we led here showing the use of machine perfusion, so a portable OCS device for DCD lungs. We had 100% survival at 30 days and 94% survival at 1 year. So this really was hard to compare with that. We did have a little bit more graft dysfunction than we'd seen in standard donors, but compared to our experience with NRP, so far, I think that machine perfusion seems to be a little bit better. This was the first DCD recipient that was done using any kind of perfusion device in the U.S. I had the privilege of doing this case, and I remember his case. I remember seeing the lungs on the device. It was a DCD. It was the first time we ever saw a DCD organ on a perfusion chamber, and you could see that it actually is acting differently. It was a little stiffer, it was a little bit more edema, but after about 3 or 4 hours on the machine device, it was starting to get softer and better, and the blood gases improved. He did pretty well. He had some acidosis the first day after transplant, but otherwise started to improve, left the hospital after about 2 weeks. He did pretty good. He died 4 years later from a GI, different unrelated complications, but related to immunosuppression, unfortunately. In the EXPAND clinical trial, this was a large prospective consented clinical trial, not randomized because we had no equipoise to use anything else, but it was a single arm prospective trial. The DCD donors did have the highest rates of graft dysfunction. So this was important to know. Even though they all survived, they did have early higher signal of reperfusion injury. So we think there's still room to improve in any of these technologies. But that's not unique to the OCS. It also, the XPS static EVLP system also had high rates of graft dysfunction early on in machine perfusion DCD organs. We did a study in a pretty large registry that we house here out of Baylor St. Luke's, and we compared DCDs with EVLP and DCD without EVLP, and at 90 days saw no difference, and in fact saw a little less graft dysfunction in the EVLP cases. This is machine perfusion, so not TNRP. There's not enough cases for TNRP yet, but this is a pretty large registry study using machine perfusion. So seems to be that machine perfusion may be okay. Now, OCS, right now, the way that you can get an organ with the organ care system is you have to use their centralized unit called the National Organ Procurement Program. So they have surgeons that they've hired throughout the country. They have 16 dispatch areas throughout the country, and they deliver the organ to you anywhere. It could be Hawaii, it could be Alaska, it could be Seattle, anywhere, Puerto Rico. And you call and they bring it. So what's happening is that we're learning from them now. We're learning from their surgeons. Some of their surgeons we've worked with in the past. Some of them were procuring surgeons here. So they've recruited kind of the best surgeons to go. That's all they do is they procure. So they're getting good at NRP. They're getting good at all these other things, and they're kind of learning things. So I probed them and I asked them, what's their experience been? This is not published. It's just anecdotal. And they say basically NRP is hard. It's tough for them to recruit the lung. They see a high incidence of lung non-utilization. So they end up wasting a lot of the lungs. However, they did mention that they have successfully procured 7 lungs using NRP, passed the litmus test, went to the OCS, and then were transplanted. They said that the keys to success that they've noticed is rapid chest opening, of course, clamping the head vessels right away. That is mandatory anyways. Cannulating the right atrium, decompressing the heart, cannulating the aorta, starting the NRP initially with low flows, starting at about half or less of the cardiac output, placing a purse string in the pulmonary artery and inserting a pump sucker into the pulmonary artery, so a PA vent, basically, very early in the process. Keep the heart decompressed, keep the lungs decompressed. Then increase the NRP flow to full flow very slowly. Maintain low tidal volumes on the vent initially to protect the lungs at first. But once it starts flowing and once the heart's pretty decompressed, then gradually increase the tidal volumes to 6 cc's per kilo. Then wean off the NRP, and then the rest is like a brain dead donor. And they say, even though you still lose some organs that still have a lot of edema, but they've been successful at least in 7 cases. This is interesting to think about. So financial implications is one of the drivers for NRP right now in the US. Is there's obviously, we all want to contain costs. We want to have the same quality with less cost. It's a federal mandate, and it's important for sustaining medical operations in the US. So this study looked at machine perfusion compared to NRP. So bringing perfusion teams out there with a cardiopulmonary bypass unit compared to a machine perfusion device like OCS. And this is for heart. So this is a heart in the box. And you can see the charges. So the direct costs were about $80,000 more with machine perfusion compared to NRP. So that was real. However, it was not statistically significant. And this is because there's such a heterogeneity in costs. So you may have some costs extremely high for one patient in the NRP patient group and one very low for the machine perfusion group. So, and when they look at the charges, they charge more for machine perfusion cases than they do for the NRP cases. They get paid more, so Medicare reimburses more for the machine perfusion cases. And at the end of the day, a little bit less contribution margin, but it's similar. It's not statistically significantly different. But I think if you did this 100 times, you would certainly notice that NRP does seem to be a little bit more cost effective, but it's going to take hundreds of cases to really see the difference. So is it necessary for lungs? I would say it's not necessary. You know, if it becomes a financial issue, we're going to have to learn how to do it successfully. Does it improve lung function outcomes? I don't think so. I don't think it improves lung outcomes. Does it place the lungs at risk? I think it probably does. Yeah. And are there ethical concerns? Maybe. So most of the data available for DCD lungs involves standardized. It was that registry, 5-year DCD registry I showed you. And the next most amount of data that's high quality is machine perfusion for DCD organs. There is limited data for DCD organs using NRP. DCD livers with NRP may do better than a standard donation, direct acquisition, but that's level 3 data at best. But machine perfusion also does very well in randomized controlled trial. DCD hearts do better with TA NRP than nothing, that's for sure. But machine perfusion also results in pretty good, very good outcomes for DCD hearts. So future directions, ultimately, I think costs are going to be a major factor, but absolutely modern day innovations with machine perfusion of isolated organs is at a state that it's definitely available to reduce any potential risks that are out there with NRP to the donor lung. In the meantime, we need to continue to monitor progress with TA-NRP for DCD lungs. Our team remains hyper-selective in those cases. We exercise careful and methodical procurement techniques, excellent venting, gradual ventilation, slow perfusion rates at the beginning, gradual increase. And we do just, no matter what, no matter how good it goes, we expect and we prepare for some degree of pulmonary edema in the recipients. And we think about that when we accept the organ. So is it a low-risk recipient, or is it a 70-year-old recipient that will not tolerate a day or two of that kind of pulmonary edema? So we factor that in the decision-making. And with that, I conclude all the slides. So happy to take any questions. Thank you.